Hey everybody, it's Dr. Becker. This is chapter 86, and it says it's drugs for cancer pain, but this is true, but it really also covers pain management in general, especially inpatient, outpatient type of just pain management. We've already talked about pain medication thus far, so this is just a little bit different approach to it. I don't love the way that Laney's does this, but we'll see what we can do here with this chapter. It does make some good points, and at the end of the day, it's really important. What we're going to focus on is making sure we understand the stepwise approach in cancer pain treatment and in pain management altogether. The thing that's really important to distinguish and why they kind of make this a separate chapter, I think, is that there's a difference between pain management in non-cancer patients versus cancer patients. And the reason that that is a distinction is because cancer pain hurts, not that other pain doesn't, but it's a definite intense pain that it's more like, I would say, you almost can't argue with, for example, right? And so cancer pain in general is accepted that it really hurts and it tends to be treated and needs to be treated aggressively and appropriately. So maybe not aggressively, but assertively, maybe that's the better word to say, versus people with chronic pain, people with neuropathy, people with a chronic major back injury. Those are devastating, painful injuries as well. But what I'm saying is that when patients have cancer-related pain, there is a little bit of nuance there, especially when it comes to the treatment of bone pain. And what we find as healthcare providers is that we tend to undertreat cancer pain, which in my opinion is like the worst thing to do ever, right? But I also work in palliative care. I know my perspective is a little skewed, but I've always felt that way. You know, we have to do it safely. We have to do it appropriately. We're not going to abuse pain medication, but there really is this distinction to call it cancer-related pain so that as you are as a prescriber, you can have that perspective. Like it should trigger your mind to think, I really need to make sure I'm treating this pain appropriately. One of the first things Laney's talks about in your book is the box 86.1, and it literally says in there, barriers to cancer pain management. So when we interview healthcare providers and we look at how well do we manage cancer pain, we tend to manage it worse than we do quote unquote routine pain. Okay. So one of the things is that, number one, there's an inadequate knowledge of pain management or a poor assessment of pain, and then concerns stemming from regulations of controlled substances, fear of patient addiction, concern about side effects, and concern about tolerance, right? So from the healthcare provider's perspective, we don't always do very well. And I am not minimizing these concerns. When you are in practice, you are yourself going to be hesitant and cautious and just really wanting to make sure you're not overdoing pain management, which is fine, but we also have to make sure we're also adequately pain managing people. And then you're going to run into problems with patients, not problems, but barriers, because they have a reluctance to report pain. They have a fear of distracting the focus from the cancer to the pain management. They have fear that pain means the cancer is worse. They have fear about addiction. They have fear about unmanageable side effects. There's generations of people that just absolutely think taking a pain pill or an opioid is like the worst thing in the world. And then they're worried about becoming an addict after one dose. So I bring these up because it is important to realize when you're thinking management of pain and management of cancer pain, there are these barriers. And overall, when we are interviewing patients and their families on their perspectives of pain management, we tend to do worse with cancer-related pain than general pain, but we also don't do well generally in pain. I'm going to take a second for a soapbox here, and fast forward through this if you'd like in terms of a soapbox. But part of the problem, I'll say, with pain management from my perspective, anecdotally, as me as a provider, has been that just like so many things, the pendulum swings too far one way or the other, right? So the pendulum, for example, is that for a long time, we realized that people weren't treating their pain or getting their pain adequately treated. So we knew that, we saw that, and it just wasn't working well. Okay, people weren't getting their pain treated well. And then we got into a situation in the healthcare system where we started basing the payment to the hospitals based upon performance. And part of those performance measures was patient satisfaction. So then during that time, we created the idea that pain is the sixth vital sign, which is great, right? Like the purpose of that move was to say, hey, we have to fix pain. We have to acknowledge pain. It's important for the patients to feel like their pain is managed. So this big kick came to really pay attention to pain, which is great. But then, just like anything, the pendulum swung too far. And now we had people giving people pain medications to get good scores. Now, I'm really simplifying that, obviously, like it's so complex and multi-layered. But really, in healthcare as a provider, you felt that way. You weren't allowed to say no. You weren't allowed to say that's not an appropriate treatment intervention for where you're at, because if they gave you a negative review and they answered the question that their pain was not well controlled, it affected payment. And so then, we went way too far the other direction. We became very liberal in the general sense of pain management. Well, then we started having overdoses and problems and addictions and all those things that come with that. An abuse arose from that, or overuse arose from that. Not intentionally, not with bad people. It just was people became too liberal, right? So you'll hear stories about what was happening. An example would be a 19-year-old kid had a jet skiing accident and kind of got all banged up and, pulled his back and did something, but they weren't like life-threatening injuries. And we were so liberal with the pain medicine that kid who's in good health would go home with like 120 high tablets of oxycodone, for example. And then we were seeing where they were taking it and they were like, oh, this stuff is great. And then they kept taking it and then they'd ask for a refill and they'd get the refill, and it kind of perpetuated these problems. And then they would become addicted and have these issues. And then, that led them to the use of illegal drugs once the prescriptions ran out. I mean, if you look into the history, that's what was there. There's a ton of stories like that happened, where you'll hear a mother say, I blame this provider because they started giving my 14-year-old or my 18-year-old or my 21-year-old child really high doses of pain medications that were inappropriate because we were overdoing it like that way. Adults, older adults. I mean, it wasn't just like young children. Okay, so then the pain management swung way too much that way. We started having overuse and abuse and issues and overdoses and all those things. And we knew that the rise of fentanyl and synthetic fentanyl has been on the rise. And so now you have an opioid use disorder issue. People were easily wanting then to transition into synthetic drugs, illegal drugs, etc. So then we wanted to swing the pendulum back, but instead of getting back to midline, we've kind of swung a little bit the other way, in my opinion, where now it's so heavily regulated, it's like difficult to even give a pain pill to somebody. And again, in my opinion, it's just a little bit too far left or too far right. I feel like the happy medium we just haven't been able to land on. These are my opinions. But when you're into practice, there's a difference between being scared to give a pain medicine and appropriately being cautious and critically thinking and having an appropriate stepwise plan and approach. Because there are going to be people that need pain medication, especially cancer-related pain. So what I mean is that being cautious and thorough and making sure you have complete history, that you've done your stepwise approach, that you have a good understanding of risks and benefit with your patient, that you have good goals together, that it's a shared decision making of what you and your patient as a team are trying to achieve. And you do all those things and it's appropriate, then use the pain medicine. So I hope that my perspective, I know it's a little bit of a soapbox, but I don't want you to have fear of, oh my gosh, I don't want to give any pain medicine because I don't want to do it wrong. And I don't want you to be like, I don't care, I'll give everybody pain medicine, because that's not right either. But if you do these things and you manage it appropriately, then that's an evidence-based practice approach, and you are likely, hopefully, going to adequately treat people's pain. So if you made it through that, that's my spiel. Just make sure that you're cautious and you're intentional in what you're doing with your pain management as you come across. patients that need pain management. Okay, that's my spiel. Okay, remember that pain is a big deal because it's a quality of life issue and it's a heavy burden for both the patient and for their family. It has heavy socioeconomic issues associated with it because pain often prevents people from functioning in their day-to-day life, which also means that they don't do well at work or they can't operate and drive machinery or whatever that is. Pain and uncontrolled pain is directly related with substance use disorders and mental health issues, right? So people that live in chronic pain, those people tend to have anxiety, depression, suicidality, just limited quality of life. It's really problematic for them. So I don't want to undermine pain. Yes, you are going to come across people that are abusing the system and that you feel don't need the level of pain medication that they're asking, but those people shouldn't take away from those that do also need it. Okay. So to discuss the idea of cancer pain can be caused through direct invasion of surrounding tissues. So it can be in nerves, it can be in muscles, it can be in our visceral organs, and it can be at distant sites from that cancer site. And metastases to bone is very common, causing pain in up to 50% of patients. Cancer can cause neuropathic pain through infiltration of nerves. And that is no joke. That pain is very painful. And then if it's in our solid organs, that's more of a visceral pain because we can also have infiltration into the organ. But when we also get the organ not functioning well anymore, that's not good either. The incidence and the intensity of the cancer-induced pain is likely very closely related to the cancer type and to the stage of the disease. Among patients with advanced disease, 75% will experience significant pain. Of those 75%, 40 to 50% is moderate to severe, and 25 to 30% is very severe. So that's why I'm saying we have to be cognizant that people with cancer, when they're relating pain, it tends to be very severe. Okay, there's a multitude of different options of how we can treat patients with pain and cancer pain, which is what we're going to talk about here. So the process and the strategy that you're going to develop with your patients for pain management is going to be an ongoing process that involves repeating the cycle of assessment, intervention, and reassessment. It's ongoing. So you're not going to start off one day and say, this is how we're going to manage your pain, forever. Nope, we're going to try this, we're going to reevaluate, we're going to reassess, and it's a constant ongoing process. Our goal when you're in a pain management situation is to create the flexible treatment plan that can meet the changing needs of an individual patient. Okay. Management begins with a comprehensive assessment. And I cannot emphasize the comprehensive assessment enough. Okay. If you're going to discuss pain management with a patient, you have to sit down, pull up a chair, and say, let's go through this. And you have to do a great history and assessment, and history and physical. Okay. Because you need to know, when did this start? How did it come about? What are all the factors? And then you need to know history, right? It's important to know, well, 20 years ago, I was in a really bad car accident, and that's when I had XYZ injury, right? All of that can play into how you're figuring out what you're going to do for your patient. So really asking the questions is going to be very, very important. This is figure 86.1, which has created a flow chart for you that talks about pain management. So at the top, again, is this comprehensive assessment. So you're figuring out, do they have no pain? Do they have cancer pain? Do they have pain unrelated to cancer? So let's kind of go down this flow as we talk about this, okay? After the nature of your pain has been determined, a treatment modality is then selected. Analgesic drugs are preferred and hence are usually tried first. If drugs are ineffective, other modalities can be implemented. Those are things like radiation, surgery, nerve blocks. After each intervention, pain is reassessed. When you have relief and that's been achieved, the effective intervention then can be continued, accompanied by frequent reassessments. A new comprehensive assessment should be performed, followed by, again, appropriate interventions and reassessments. Throughout this process, the healthcare team should make every effort to ensure active involvement of the patient and his or her family. Without the involvement of the whole support of the patient, maximal benefits cannot be achieved. Okay. So this is a nice kind of flow sheet that will tell you what we're talking about here. So when it says that cancer pain initiate analgesic ladder, we'll talk through about that. We're going to go through these in a little more detail here. Okay, so one of the things that they jump into, first let's talk a little bit more about the comprehensive assessment. There's a patient's self-report, and they get to say what it is, right? You know how we always hear the expression, the pain is whatever the patient says it is? The patient's description is the cornerstone of the pain assessment. The best way to ensure that the report is accurate is to ask the right questions and then listen carefully to the answers. We don't want to just say, so how do you feel? How does it feel today? We need a guided interview that's going to go with it. Then you need a physical and neurological exam because we need to characterize the pain, try to identify the source, and then identify any complications related to the underlying pathology. Okay, so for example, the clinician should examine the site of the pain, determine whether palpation or manipulation makes it worse, look for the nonverbal cues. Are they guarding? Are they grimacing but not saying anything? For example, if the patient has hip pain, the assessment should determine whether the pain actually originates in the hip or if it's referred pain caused by the pathology in the lumbar spine. Potential neurologic complications should be considered. When you get into your physical health assessment class, you're going to learn all of these health assessment techniques to determine low back pain, those kind of things. Then you're thinking motor and sensory testing to figure out if it's neurologic type pain, neuropathic pain, those things. Okay. And then we have to think, do we need diagnostic testing? And most times it's yes. We want to see, is there a tumor there? Has the cancer worsened? Is there potentially a bone-related fracture in the area? You got to still make sure that we know why the pain is there and what's causing it. You don't want to miss, for example, a fracture or those kind of things. So oftentimes you get a CT scan, a PET scan, those kind of things. The next part about the assessment that your book goes into that I do think is done well in this chapter is to make sure that you're also understanding the psychosocial. And that's the part where it can be both with the patient and their family. So you want to know how the pain's affecting them in their life. How are they able to function? And how is it affecting their life at home? How are they coping? Are they smoking, drinking, using marijuana? What over the counter? Are they using herbal supplements? What are they doing to manage, and is it effective? Do they have their own concerns and anxieties about the possibility on being on opioid medications? And then are they having enough support and help at the home? Because all of those things are really important. If you don't have good support and you're stressed out and you're not whatever, your pain, we know, is going to be amplified, right? They're going to be bothered by it more if they're struggling in their psychosocial world. So part of a pain management assessment does include a thorough H&P. Really, y'all, we want to know surgeries, physical exam, all of those things are really important to get a really in-depth history, and the psychosocial is part of that. All right, when we talk then about the drug therapy, this is where the idea comes of this ladder for pain management, okay? So this is supported across the healthcare system in America today. Like all of the associations, everybody pretty much has adopted this same kind of step level. If you're in bigger healthcare systems, oftentimes you have a pain management or a pain team or the interventional pain people. And so oftentimes, you also have pharmacists that are going to tell you, you can't just start that drug until you've documented step 1, step 2, step 3, whatever. This is where they're coming from with that, okay? Analgesics are the most powerful weapon we have for overcoming cancer pain, and they can alleviate pain successfully in over 90% of cancer patients. Because analgesics are so effective, drug therapy is the principal modality for pain treatment, okay? So we start at level 1, which is non-opioid analgesics. So always first, you start with these and by always, I mean the majority of the time. Are there some exceptions? Sure. But for right now, for the purpose of pain, even in non-cancer pain, you start at number one. You say, can they take an NSAID? Can they take acetaminophen? And you give it time. So this is not just, well, take it if you need it. This is maybe you schedule twice a day or 3 times a day acetaminophen. You schedule right away, for instance, in the morning, a 600 milligram ibuprofen. These are the things where you use diclofenac gel and a lidoderm patch, and you use that for, let's say, a month worth of time, and then you can reevaluate. Is it working? Is it helping? Those things. You need to exhaust level 1 to whatever that looks like. Now, if you have limitations that they have bad liver, they have bad kidneys, whatever, then you document that, or you document your thought process that I don't have any other non-opioid choices at my disposal. I've used them all. But that's a really important point, is that at level 1, we need to exhaust those. Now, for both cancer pain sometimes, but especially for pain in non-cancer patients, part of level 1 is often also considered physical therapy, occupational therapy, massage, acupuncture, chiropractic. Some of those interventions people will consider at level 1 as well. So in other words, we want to exhaust the things that are non-opioids, okay? Then with level 2, we say, okay, level 1's not cutting the mustard. We've reassessed our patient. They're still having pain. We're not being successful. We go up to level 2. Now, that doesn't mean you stop all of level 1. In fact, almost always I keep it. So when I'm doing palliative care or hospice care, I always will continue with those non-opioids, the Tylenol, the ibuprofen, the diclofenac, whatever we're using, because I know that that is still helpful, and then we can add to it as we need to. There's not a lot of times that people just stop all level 1. We add to it. And then that is mild to moderate pain is still there, and we still are considering plus or minus non-opioid, plus or minus adjuvant, okay? And then level 3 is when we consider adding on an opioid again. So it's the first, or excuse me, that second step is when we're doing more of our mild opioids. Think hydrocodone, think tramadol, think even like low doses of oxycodone or low doses of morphine. But we're talking low, okay? Low, small doses, infrequently used, low dose opioid. And then level 3 is when we consider more higher dose oxycodone. We consider fentanyl, morphine, hydromorphone. Those are the ones that are more into level 3. When you also go down to table 86.1 in your book, you're going to see drugs that are not recommended for treating cancer pain, and they just don't work well. They don't have a role really, and so you're just not going to see them. Number 1 is Demerol or meperidine. We just don't use it at all in practice. Some maybe for the hiccups. I wouldn't be surprised if you encounter facilities that don't even carry it, or they carry it only for PACU with shivering or some of the very specific things, because it can build a toxic metabolite. Then is codeine. Codeine is a very weak pain medication, so we don't use it much. The other ones that are listed in here, the opioid agonist antagonists are listed here that have buprenorphine, nalbuphine, pitazocine, whatever. This is not true, okay? Remember, this table is called drugs that are not recommended for treating cancer pain. Not true. We now know that buprenorphine has a wide role, and you will possibly see it in the potential for cancer pain, especially for elderly people because of the ceiling effect and the decreased risk for respiratory depression. So this is no longer accurate in that way. But some of those other ones, no, I would say we don't see as a lot. Typically in cancer pain, you're not giving naloxone or naltrexone because you can precipitate withdrawal. And then this one, in terms of treating cancer pain, the benzos, the barbiturates, and the miscellaneous. The benzodiazepines have a role in cancer treatment pain by a specialist under certain circumstances. The issue is that you can get into an over sedation situation and have a change to the respiratory drive. Okay. But there is a great relationship between a benzo and an opioid, especially as you're getting into advanced palliative care, closer to end of life care. Definitely in end of life care, we use the mix together. But what they're saying here is that in step 2, you're not going to add hydrocodone and like 3 times a day Ativan or something, right? Because if our focus is pain direction, benzos aren't necessarily one of the first things related to pain. That's a mixed topic of conversation. If you had a different instructor that wasn't me, you'd probably not even be having this discussion. But for the purpose of the book, when you're talking about step 1, step 2, step 3, benzos technically don't fall into the pain management step. The book goes into now talking about the National Comprehensive Cancer Network, recommends a different approach for pain. And so I back up. What I said before, that you always start at level 1 with a non-opioid, whatever, this is still very true. But what they're talking about here is that if you have a patient that has cancer pain and they're coming to you and they're like, my pain's a 6, in the situation of cancer, what they're saying is it is reasonable to start an opioid at the beginning while you're working on their pain management. And I do agree with that. An initial trial with non-opioid is considered unnecessary. And they say that if they're only rating their pain a 1 to a 3, then treatment usually begins with a non-opioid. In practice, I would always still start with non-opioids. So even if someone comes to me and we found out, that they have this metastatic cancer with bone pain and whatever, yes, maybe I'm going to start them with oxycodone because they're in agony, but I'm still starting Tylenol or lidoderm or whatever it is. If there's any role, I will also start it because it's helpful to hit pain from all the different receptors. But what this section in your book is trying to say is that you're not going to have someone who comes to you with excruciating back pain one day and you realize that they have like metastatic cancer up their spine, throughout their ribs and whatever. You're not just going to send them home on Tylenol and be like, call me in a month, right? What they're saying is that those are people that probably start with an opioid right away because they're in excruciating pain. But part of their management still is the consideration of the non-opioids. And I still do start people on Tylenol twice a day, for example, unless their liver, but like if I had a prostate cancer gentleman who showed up in their 70s with this horrible back pain, they woke up with it one morning, turns out they have stage 4 cancer and it's all through their spine, I'm still starting Tylenol. I'm still considering heat, cold. I'm still considering diclofenac. I'm still considering all those things while I'm also starting them probably on like oxycodone or something, right? What the purpose is of they're saying is you don't send those people home and be like, call me in a month and see how it goes. No, we know they're going to need opioids, but it doesn't mean that you neglect the step 1 other non-opioids either. Hope that makes sense. The other kind of nuances here is we always try to do oral first, avoid IM whenever possible. For persistent pain, when we're really getting into now pain management in a cancer patient. So in other words, sometimes you get away with oxycodone every 4 hours and you kind of see how they do. And once you get them over like the initial hump, maybe they're only needing their oxycodone once or twice a day. One day it's 3 times a day. The next day it was just 1. Okay. Those people don't necessarily need around the clock dosing. However, oftentimes in metastatic pain, especially, they do need around the clock treatment. And so if that's what they need, then sometimes they end up on a combination of long acting and short acting. And you want to make sure that you have the breakthrough pain options there as well. And again, this is an ongoing cycle, right? When I do pain management for my cancer patients in palliative care, I am in frequent contact. Number 1, I'm also doing palliative care for all of their symptoms for them and their family in that line of support. But if I'm also managing their pain management, there are times in the beginning where I'm talking twice a week with somebody, maybe, for 2 or 3 months to start with. And sometimes for a long time, we're really in close contact. Sometimes then once I feel like we're stable, I'll say, okay, I'll see you in a month. Call me if you need me. But it's really close monitoring and adjusting as needed. The book then goes into talking about the different drug therapies. Again, we know now we've covered NSAIDs and how they work. Remember that you're at risk for gastric ulcers, renal failure, those things increase bleeding. And so if you're dealing with cancer pains and they're on cytotoxic, if they are on cytotoxic drugs that would lead to immunosuppression, we have to be cautious with our NSAIDs because we don't want somebody taking ibuprofen 800 milligrams 3 times a day and their platelet count's 40 and they're already anemic, right? That's not a good plan. So those are things that are used very cautiously and closely. Okay. And then it does, as it goes on down here, it says, which is what I was getting at, is that we actually know that having this basis of non-opioids with an opioid works better than opioids alone. So remember that there is roles for them. And even if these people with cancer pain are on large doses of opioids, I still have them on their Tylenol. And if it's more of a hospice situation, I sprinkle in some NSAIDs in there if that's what we need to achieve pain control. Okay, and then we talked about acetaminophen. We've already visited with that. It's really important to remember, though, that we should be careful with our liver functions and making sure that if they're on the chemotherapy or those drugs that could affect liver, that we're paying attention to Tylenol doses and our liver function tests. Okay. Opioids, again, are useful for pain, but then we have to remember that they also have the possibility of sedation, respiratory depression, euphoria, and then they have some negative side effects. Those are negative side effects, additional negative side effects. And those are things that can really be problematic to the patient. And those two things are constipation. Remember, we talked about it, that these opioids can actually reduce the colonic motility, and it can also actually reduce the sphincter of the rectum and anus to actually be able to relax enough to pass the bowel movement. And two, it can cause urinary retention. And these are significant things that are associated with pretty much all of the opioids. So yes, we know euphoria, it can make him too sleepy, and respiratory depression. Obviously, those are life-threatening things. We talk about that. But don't forget that there's also these other things. Sometimes it causes them itching. Some of them make people nauseated. So there's the potential that even though they can be very helpful for pain, they can still have their own set of problems associated with it. Okay, opioid analgesics relieve pain by mimicking the actions of endogenous opioid peptides. So in other words, they mimic the actions of like our endorphins, right? And we always know endorphins make us feel good. They work primarily at the mu and kappa receptors. Based on their action at these two receptors, the opioids fall into the two major groups. We're reviewing this again. One is the pure agonist, which is a full agonist, which is morphine. And then agonist, antagonist, which an example is the butorphanol. The pure agonist can be subdivided into mild to moderate or moderate to severe pain. The pure agonists act as agonists at the mu receptors and at the kappa receptors. But in contrast, your agonists, antagonists act as agonists only at the kappa receptors, agonists at kappa, and antagonists at mu. So they have a ceiling effect to their analgesic effect, which is like buprenorphine. And because of their antagonist actions, these drugs can block access of the pure agonist to mu receptors and can thereby prevent the pure agonist from relieving pain. So what we're saying is that morphine, hydromorphone, those drugs are pure mu and kappa agonists, okay? When you're on the drugs that are the agonist-antagonist drugs, those are already antagonizing mu, so they're already kind of blocking the mu receptor. So what happens is if someone's on buprenorphine at higher doses, or they're on like Subutex, the buprenorphine naltrexone, and then they need high doses for pain management for some reason, you have to give pretty high doses of the pure opioids to overcome the mu receptor activity. So let's review again the idea that there's tolerance of a drug and there's a physical dependence. There's neuronal adaptations to prolonged exposure of the opioids. And we talked about those in the chapter 31. So think about that to remember. Obviously, this is applying to these drugs as well when we're talking about the opioids. For all cancer patients, pure opioid agonists are preferred. This is true. Again, there's some in the literature now that buprenorphine is very effective for some people and is used a little bit more. But for the purpose of this chapter, we're thinking pure agonists for the cancer pain. They consider oxycodone to be a moderate and morphine to be a severe strong. Morphine's been around forever. It's inexpensive, and we have it in multiple ways to be given: sublingual, rectal, buccal, IM, IV, all sorts of things. We can give it inhaled, right? So morphine, we pretty much have every route possible to give it in. Your table 86.2 has your the Equia analgesic chart, which is nice to kind of give you the reference of the potency of one drug to another. So if you give morphine 30 milligrams by mouth, that's the same as giving oxycodone 20 milligrams by mouth, or hydrocodone 30 milligrams by mouth, etc. So there's some conversions there that are good to know. And when it says the conversion factor, so parenteral to oral or oral to morphine. So in other words, for every one of oral, I take that back. It talks about the parenteral to oral opioid conversion and then the oral opioid to oral morphine conversion there as well. And then it does give you your dose chart options there that you could review that more if you wanted to. There is a definite realm, if that's the word I'm looking for, role is what I wanted to say, a role for opioid rotation, switching from one opioid to another, because opioids have different side effects and rotation can help minimize those adverse effects while continuing good pain control. To make the switch, the current opioid is abruptly stopped and immediately replaced with something else. When I do this, it's usually morphine to hydromorphone or hydromorphone to fentanyl, or kind of rotating between those three for people that do it. It's kind of like trying to trick the body and not to become too tolerant to one, and to kind of make sure we're not getting metabolite buildup of like your morphine, etc. Methadone and levorphanol can be used in caution, but the problem with those drugs is that they have an extremely long half-life. And so that makes it really difficult to use. And codeine is just not good for pain control. The dosage that you start with are individualized. The idea still is low, start low and go slow, and that continues on here as well. Remember, we have to be kind of creative sometimes with our route of administration. We have to have a plan for breakthrough pain. And you guys are reading these chapters. I'm not going to sit here and read all of that to you. Managing the side effects. We've already reviewed a lot of these in chapter 31. But sometimes all you need to do is reduce the dose and the side effects get a little better. And again, opioid rotation can work as well. Then they talk about these adjuvant analgesics. And these are meant to complement the effects of opioids, not to take place of them. So you use them in combination. So number one, they can actually enhance or amplify the effect of analgesia. And two, they can concurrently manage other symptoms that could make pain worse. And they can also be helpful to treat possible side effects of the opioids. Especially useful is for neuropathic pain. If a person's pain is primarily neuropathic, you're not going to get very far with opioids. They just don't work effectively. You need these adjuvant analgesics. So adjuvant analgesics like this may be employed at any step on the ladder. They can relieve pain, but they can also sometimes help with seizures and like depression or dysrhythmias, etc. So sometimes you can get, kill two birds, one stone adding on these ones. So the first ones they talk about are the tricyclics, and these can be really good to reduce neuropathic pain, and they can also be sometimes good to help with sleep or insomnia. The other antidepressants we know now that duloxetine and venlafaxine have both been studied and shown to be helpful in reducing neuropathic pain. I use duloxetine a lot in practice because it can help kill the two birds, one stone, that I can start addressing their depression as well as the possible neuropathic pain. Some of these anti-seizure medications, such as gabapentin we know about, and pregabalin, are drugs that are commonly used with neuropathic pain. The topical Lidoderm, love it. I use it a lot. CNS stimulants can enhance analgesia and reduce sedation from opioids. The other thing about it is that there is a role to use methylphenidate, which is Ritalin, in possibly even cancer-related depression, or especially in hospice. We actually use Ritalin a little bit now as well to help give them a burst of energy because we're giving them such high doses of opioids, and to help kind of give them a boost and improve their quality of life. The next thing to consider, and this should be a gold star for you somewhere in your mind to remember, one of the best ways you're ever going to treat bone pain associated with cancer, right? So not always, yes, it would work for other bone pain, but for the purpose of what we're talking about here is metastatic bone pain responds incredibly well to glucocorticoids. Especially dexamethasone seems to be one that is used quite a bit. And dexamethasone, like we talked about previously, can be associated with reducing swelling in the brain for brain metastases, or spinal cord compression, which can also cause excruciating pain and symptoms. So in your back pocket, if you think bone pain, think glucocorticoids, and especially if you're thinking metastatic brain or spinal cord compression, those are going to be treated with big doses of dexamethasone. The other thing is that sometimes giving people the bisphosphonates can help reduce hypercalcemia and help possibly decrease bone pain. So those are pretty nice things to talk about as these adjuvant things. Okay. This next part is something that I am still amazed at in practice that we just don't always do a great job on, especially in my role that I see for palliative care. And so what I mean by this is that there are a lot of non-drug options that we should consider. If we're going through our ladder and we're just not getting there, we're just not getting great pain control, considering these other non-drug therapies. I have sent cancer patients to physical therapy, depending on where they're at in their journey, those kind of things, but also interventional pain and nerve blocks or the implantation of pain pumps. I've encountered people that have the mentality of, well, they're a metastatic prostate cancer patient or they're a metastatic breast cancer patient. Their life expectancies may be less than a year. Do I really want to put them through a procedure? So they kind of avoid that. And my answer is absolutely yes. Are they the miracle cure-all? No, but they can be super effective for people. So if you have somebody with especially really bad spine metastases and you do an intrathecal pain pump, you can buy them great quality of life, and also I think you can buy them maybe more time. Because if we're doing the intrathecal route for pain management, we're not having the overall sedation. They can remain more awake, alert, they eat more, and they remain more active. So you could buy them days, weeks, or a month or two. In terms of pain, nerve blocks are great. Radiation therapy is something to consider. All of those things are something that we should consider. So if you're dealing with a patient with cancer-related pain and you're kind of moving through your ladder and their still pain is just such a big deal, think to yourself, what about an interventional pain specialist? Should I have them have an e-consult or their chart to be reviewed, or at least discuss it with somebody? Is there anything that could possibly be helpful? Could I block something? Is there a nerve block available? Is there a radiation treatment available? What could we do to help? The other main point in all of this as well is patient education. And this, when you're doing pain management with somebody, you have to educate them well. You have to you have to treat the pain, but you also have to treat the patient's education. They have to know what you're doing and why. So I am telling people, okay, I'm writing it down on a piece of paper. I am treating you with long-acting morphine twice a day. So this one here, and I'd show them on the paper. This is for around-the-clock pain management. You will take this every day at 9 a.m. and 9 p.m. no matter how you're feeling, unless you're feeling like unresponsive, right? But even if you're having a good day, you still take it because this is the reason why. This is your breakthrough pain. This is the dosing. This is how you can take it, okay? I'm starting you on duloxetine. It's a medication that can be used for both depression and neuropathic pain. I'm using this because of this. These are the possible side effects, but I think this is a good drug to be on, and this is the why you're doing it, okay? All of those things. These are the possible side effects people can have on the long-acting morphine. These are the things I'm worried about as your provider. We have to make sure we're really diligent about your bowel movements, and we educate, and we talk ad nauseum, and I tell them I'm putting you on the Senna, and I'm putting you on the Miralax, and I'm doing all these things, and I want you to keep a diary every day. Diaries are huge for me. A pain diary and a poop diary, or a diary of every day. When did you last poop? Is it hard? Is it firm? Nausea, vomiting, what side effects you're having. And when you come back for your follow-up appointment with me, let's bring that diary so I have all the information I need to make any possible adjustments. But we want to tell them the dosing, the scheduling, the why of why they're taking it, and the duration of treatment and what you're hoping for. One of the most important things in general for all people with pain, whether they're cancer pain or not, but I tell them, my goal for you is not to eliminate and eradicate any pain, especially in cancer pain, you guys. So I tell them, I want to make it tolerable for you, comfortable for you. I want to improve your quality of life. I'm not sure I'm going to get it to go away completely. It might be a 1, a 2, or a 3, but that's what I'm shooting for because I still want you to be awake. I want you to be alert. I want you to enjoy your time with your family. And that's important that we establish our goal from the start. Because if their goal is to have absolutely not 1 ounce of discomfort and my goal is to get them to a 3, we're not on the same page. I also do this with their spouse, their partner, or whomever's kind of their point person. They are there for all these conversations as well. And I'm educating them on these are the things I would want you to call me about. Or, if you're seeing these symptoms, if they're too sedated or if they're too whatever, this is what they're on. This is the why. If they ever had to go to the hospital, this is what they're taking and all those things. So the patient education is huge. And I always end up talking about the possibility of tolerance, the possibility of dependence and addiction, making sure any of their fears or their concerns I've had the opportunity to address. All of those things are very important. So at the end of the day, this chapter, I hope your take-home message that you've understood here is that you go through kind of the stepwise approach. You go through the recurring, ongoing evaluations, right? Like this one tells you here. If we have cancer pain, are we considering unacceptable side effects? Are there bone pain? Is there neuropathic pain? Is there movement-related pain? Is there also mucositis, right? So all of these things that could be related to their pain, we're constantly looking at, evaluating, reevaluating, reassessing, right? It's kind of this ongoing process, but it all begins with that initial assessment that is a thorough H&P, including previous surgeries, socioeconomic, psychosocial, their mental health, their financial health, what factors could be barriers to them having pain improvement. I mean, these aren't anything new, right? You're going to learn this. You do this with all your H&Ps, but it's also really important for pain that you keep it wide and comprehensive and do a really good pain assessment. Okay, and then as always in my documentation, I'm always documenting what I've done in the past, my justification or my reasoning of why I picked this drug and why I think it's appropriate, et cetera, et cetera. And then kind of talk about my assessment and my reassessment. I put in there my patient education, all those different things. As always, please reach out if any questions or concerns. Thanks.